Hello, my name is Tahlia Alsop. I'm a PhD candidate at the University of Queensland in Australia and a physiotherapist. I'm presenting here today on behalf of our research team, who's listed here on the slide, on our study titled Perspectives of Health Professionals on Physical Activity and Sedentary Behaviour in Hospitalised Adults, a Qualitative Systematic Review. So it's well evidenced that hospitalised adults are highly sedentary and physically inactive. So patients admitted to hospital spend 87 to 100% of their time sitting or lying in bed, and they take an average of less than 900 steps per day. So we know that this falls well short of meeting public health guidelines, and subsequently it heightens their risk of adverse health and wellbeing outcomes. And critically, it can also place these patients at risk of deconditioning and hinder their functional recovery. Now, in the hospital setting, patients' autonomy over their physical activity and sedentary behaviour is quite constrained, and it's influenced heavily by the environment around them. And this includes health professionals who are well placed to influence these health behaviours. So therefore, the aim of our study was to explore the perspectives of health professionals on factors that contribute to physical activity and sedentary behaviour of hospitalised adults. We used a qualitative systematic review method, and we searched 5 databases from their inception to the 2nd of March 2023. And we included any studies that explored perspectives of health professionals on the physical activity and or sedentary behaviour of hospitalised adults using qualitative methods. And because we were interested specifically in free living physical activity and sedentary behaviour, we excluded any studies that focused specifically on exercise prescription or structured exercise programs, non-inpatient settings, and also those hospital settings with special tailored environments that might have some context-specific features that influence these behaviours. So, for example, mental health units and intensive care units. We use the McMaster Critical Review form for qualitative studies for quality appraisal, and we also assessed our confidence in the review findings using Circle. We analysed and synthesised the data using Braun and Clark's 6 stages of thematic analyses. So our search returned just under 35,000 records, and after duplicates were removed, this meant we screened just under 16,000 title and abstracts, and this led to 40 studies being included in the final review. And of these 40 studies, this explored perspectives of over 1,400 health professionals from 12 disciplines and 12 countries. Now, we identified one central theme that came out of the review, and that was that physical activity is not considered a priority in the inpatient setting. And as part of this, we had 4 key sub-themes. The first was that the hospital was perceived as a place for rest. So the inpatient setting was often seen to facilitate a culture of bed rest through the physical environment, staff, systems, and there was a favouritism really towards a risk-reductive approach to care delivery. So this was risk-reductive mainly in reducing the risk of falls and manual handling injuries. However, it really wasn't considering the risks of high sedentary time and low physical activity, and also not considering the relationship between those suboptimal behaviours and falls risk. The second sub-theme was that there are not enough resources to make movement a priority. So health professionals felt that promotion of movement could be resource intensive in what was already considered a pretty resource limited high workload setting. So they specifically reported lacking in time, personnel or equipment, and subsequently we saw that resources were typically allocated to other priority areas. The third sub-theme was that everyone's job is no one's job. So health professionals perceived there to be a shared responsibility, yet they also noted a real lack of ownership amongst the team in supporting patient movement. And they also reported that there was a reduced knowledge and skills amongst some team members, and this was noted as a barrier to supporting movement. The final sub-theme was that policy and leadership drives priorities. So health professionals' practice, their perspectives and their prioritisation of movement support was heavily influenced by the policies and the leaders within their workplace. In particular, falls prevention, manual handling and mobility-related policies really tended to prioritise the idea of safety over movement, which further contributed to this risk reductive, the hospital is a place of rest approach that tended to favour immobility and not consider the potential risks of low physical activity and high sedentary time. The strengths of this review, so we did utilise a comprehensive search strategy, and this was important given the diverse terminology to describe these behaviours across this kind of literature. So often studies did report these kind of behaviours as just walking or mobility, and less so using terminology of physical activity and sedentary behaviour. So we designed a search strategy that would ensure we captured any studies that were talking about these behaviours, even if they were using different terminology to do so. And we also had a diverse expertise within the research team, spanning qualitative research, physical activity, and clinical experience in hospital and rehabilitation settings. Some limitations of our review that warrant consideration. So we did include qualitative work within interventional studies, so this might have influenced some findings and the perspectives of those included health professionals. We did have an English publication criteria, so they might introduce a certain degree of publication and language bias. Our review was also conducted amidst the COVID-19 pandemic. So although we did exclude pandemic-specific studies, it is important when thinking about transferability of these findings to consider the impact of things like isolation protocols, visitor limitations, and staffing constraints, which exist now in a post-COVID world. And lastly, there was variability in the quality of studies. We did decide to include all studies irrespective of their quality, and this was substantiated by the fact that there were consistent conclusions across the spectrum of quality of studies. So in conclusion, physical activity is not a priority in this setting, despite its evidence benefits and its perceived importance by health professionals. The hospital is instead often considered a place for rest and really encourages a risk-reductive approach that can promote immobility. There's multi-level challenges with resources, role clarification, and a lack of clear leadership and policies. The key takeaways is that physical activity seems to be really known as important by health professionals, but how it's prioritised is more complex than that, and there's multi-level influences. So simply telling health professionals that it's important that they should be supporting their patients to move is unlikely to be enough. Instead, there needs to be a multi-level interdisciplinary teams-based approach, and it really requires supportive clinical environments that provide the appropriate resources, leadership, and policy support to promote cultural change. Thank you.